I definitely see it as part of my job to help consider medical orders and a lot of time to advocate for that. There have been many times that I go with families to, whether it's complex care, their PCP, or let PACT know, or whoever is sort of manning the inpatient palliative care ship, that this is a conversation this family that they've had, and it's more often than not something that they've been thinking about but aren't sure how to verbalize it or how to bring it up, because a big fear that I've noticed in a lot of families is that they say they want to have their child just be DNR, that they won't get good care because it looks like they're giving up. And a lot of families are terrified of that, and they don't understand the difference. They don't know what a MOLST is. A lot of PCPs don't know what a MOLST is. So they don't know what a MOLST is, or they don't know that they can just have a DNR at home but be a full code in the hospital. And so it's a big part of my role, and in sort of empowering them with knowledge to make a decision and to help them advocate. Sometimes I just have to tell the parents that, and they're like, no, I got this. I'll call the complex care provider. Or it's me making those calls and very gently connecting the two and sometimes facilitating the conversation. And so I think it's a big part of our role. It's not always. I don't always need to do that, especially if the child is improving and it's not really something the parents want to consider. I've had many times where we talk about it and we talk about it and talk about it, and then the parents decide they don't want to do anything. But at least we've had that conversation when we're not in a crisis. And that's a big part of my role, I think, is to be able to discuss it rather than have to react to it. I definitely think the home setting it's a good place to do it. And, a lot of times, generally there are two parents or two caregivers involved, and it gives a good chance for them to have that discussion, and then us come back and all have that discussion together, so we can sort of plant the seed. Mom and dad may not know what the other one wants, or they say, we need to talk about this more. We come back in a week or two, and they were like, so we've been talking about this every day since you left, and here's what we came up with, which is, I'm sure, grueling for them, but I think that work needs to happen to facilitate a good end of life, if that's something that we think is possible, or where we're heading with the child. If we know the child has a life-limiting diagnosis, whether we think the child's going to pass in 3 weeks or 3 years, I think having those conversations before, when everybody's not in crisis and functioning on adrenaline, can make that a lot easier. Because even if we're not there, the parents can be like, we talked about this with Shaylin. This is what we talked about. Are we still on the same page? And it's a 5-minute conversation as opposed to a 5-minute crisis. Oh my God, what are we going to do?